Use and mute. The webinar will be starting shortly. American Heart Month. Let's stay healthy. Health Choice Network and Alliance Chicago in action. COVID-19. Today, we're going to be talking about vaccine confidence. So stay tuned. The webinar will be starting shortly. Today, vaccine confidence. Hopefully you're confident and hopefully you're getting your vaccine. We're going to be hearing more about that in just a moment. The webinar will be starting shortly. Please join us today for our interactive word cloud. Take out your cell phone. In the to line, put in 22333, and in the message line, put in COVID-19 heroes. And today we want to hear from you. Once we can safely travel, where would be your first destination? Let's hear from you. So far, it looks like Thailand, followed up by Barcelona, Italy, Chile, the Caribbean, Rome, Europe. Where do you want to go? What's your first destination? Join us in our interactive word cloud. As you see on the screen, we have health centers all over the country involved in vaccine administration. Can you see your health center here in the pictures? We'll be starting in just a moment. Health Choice Network and Alliance Chicago in action. Today's COVID-19 series is on vaccine confidence, and we'll be starting in just one moment. So good afternoon or good morning, everybody, for wherever you are. Today, Health Choice Network and Alliance Chicago in action. This is our series on COVID-19 that we started last spring. Today's webinar is going to be on vaccine confidence. And hopefully after this hour-and-a-half webinar, we will all be a little more confident in the vaccine rollout. So today, as you can see, we're going to go over a little bit of a welcome. Then we're going to hear from our CEOs at both Alliance Chicago and Health Choice Network. Then we're going to hear about vaccine acceptance. And we did a survey before we took today's webinar, and we'll be talking about those results. Then, as always, we want to spotlight our health centers. We'll be hearing from 3 health centers across the country. And then we'll hear from the national perspective on vaccine confidence, and then we'll wrap it up for today's webinar. So thanks for joining us. Appreciate it. My name is Tim Long, and today we're going to do an interactive word cloud. So take out your cell phone, and in the to line of your cell phone, put in 22333, and then in the message line, put in COVID-19 heroes, and then it'll pop up the ability to participate in our word cloud today. And our question is, once we can safely travel, where would be the first destination that you would go? So please join us in our word cloud. We want to hear. Looks like right now people are going to Thailand and Japan. Looks like Greece is on there, the Caribbean, Chile, Australia, Portland, Europe, Rome, Barcelona, Italy. Where would you go once we can safely travel? So take out your cell phone, put in 22333, and then put in COVID-19 heroes, and then let us know where you want to go. Let's give it a couple more seconds, and we're going to hear from more people of where you want to go. It looks like someone wants to go to Alaska, I saw. Here we go, Ireland, all right. Nashville, way to go. Bringing it in, Italy, Japan, and Thailand, looks like they're winning. Italy's taking the lead there. Italy still has the lead. I don't know. And it looks like Italy might be the winner, pretty good. Someone's going to Canada. All right. Well, thank you for participating in today's word cloud. It looks like Italy is the winner. Sweden is coming, and so is Japan and Thailand. So as we start today's webinar, we want to turn it over to the 2 CEOs of both Alliance Chicago and Health Choice Network. And first, we're going to hear from the CEO of Alliance Chicago, Dr. Fred Rockman, and then he will turn it over to the CEO of Health Choice Network, Alex Romeo. So, Fred, are you with us today?
I am, Tim.
Great.
Can you all hear and see me?
Perfect. Thank you, Fred. Take it away.
Great. So it's really both a privilege and a thrill to be convening us back again today. You know, it's really hard to believe that it's just about a year ago that the first death due to COVID-19 in the US was officially announced. Could you move to the next slide? And so rapidly over the course of the next month or so, we began to find ourselves in a new reality. We had to define for ourselves a new reality. To date, there have been more than 26 million cases and more than 450,000 deaths. And despite some optimism about trends, there were more than 2 million new cases in the past 2 weeks alone. So we are obviously all tired. Our lives and our interactions are radically altered. The economy is severely crippled, and our work is drastically different today from what it was a year ago. And even worse, the communities that are important to all of us on this call are impacted disproportionately, and therefore the burden of responsibility that we bear has followed that dramatically. Could you please move to the next slide? So we now, as from early on in the pandemic, we began to gather on this series to kind of process all of it together. And throughout, I have continued to be inspired and energized by the response and the contributions of the community health centers. And these calls have been an opportunity to really share them amongst ourselves. And we temporarily suspended these webinars, and we held our annual conference in the fall. I hope that you all got to participate in that. Some of the content was recorded and is still available. But throughout all of that, we've really been able to share experience, ideas, and solutions. And I think you all probably, along with me, have found it very therapeutic to be energizing ourselves as a community. The topics of these webinars followed organically the emphasis of our response and focus. Today, I'm happy that as we reconvene these webinar series, we get to focus on a really hopeful topic, COVID-19 vaccine. Next slide, please. We now have 2 highly effective COVID vaccines, my dog is excited too, and at least 3 others appear to be slightly less robust, but still offer strong and in some cases complete protection. So there's a lot of hope on the horizon. Next slide, please. We're all really yearning through all of this that in addition to preventing death and severe disease, the vaccine is going to be a mechanism for us to get back to some aspects of our former lives. And the real hope for this lies in achieving herd immunity. We don't know exactly what percentage of the population would need to be vaccinated in order to achieve herd immunity, but early estimates were at least 70%, excuse me. And that number now seems quietly amongst public health officials to be being revised substantially upward. Next slide, please. So the new administration has been taking on vaccination as a very high priority, increasing supply of the vaccine, leveraging opportunities in the retail sector as outlets, and increasing state support. And obviously, we as community health centers are very important in that effort. Next slide, please. The exponential rise then in vaccination is really impressive. To date, you can see in these statistics, about 34 million doses of vaccine have been given, and more than 27 million individuals have received at least 1 dose, and more than 6 million more than 2. And we're giving more than 1 million vaccines daily. But if you take and look at that and digest it, the sobering reality for perspective is that to immunize 70% of the population at that rate, at this rate, would take us 1.5 years to achieve 70%, and 90% would take us more than 2 years. So even at this rate, it would be a long road. Even more concerning than the sheer magnitude of the effort is the concern over disparities. So just as our minority and disadvantaged populations have been disproportionately impacted by the disease itself, evidence is showing disparity in who is currently receiving the vaccine. Now, next slide, please. This could have several factors. And so that's why we're eager to bring this group together. We know from experience with other vaccines that differences in vaccination rates are rooted in multiple factors, not only to access to the vaccine, which we know is really important, but also in how individuals and communities process information and weigh the risks and benefits and priorities of choosing to be vaccinated. So to kick us off, I wanted to kind of reference this global perspective that's on the screen from the World Health Organization. And in addition to resources that you see from our own CHC, sort of alert you that there are lots of things out there predating COVID that help us understand some of the factors that weigh into how individuals considered vaccination as kind of a backdrop to some of what we'll be sharing today. So with that, let me turn to Alex and move us on to our panel who have such incredibly valuable things to share today. Thank you all for being with us.
Thank you, Fred. Good afternoon, good morning, everyone. Thank you for joining us again. This is the first time we come back together, as Fred mentioned, from our exciting annual conference with the Alliance Chicago Health Choice Network, Better Together, and we had the highest attendance thanks to your efforts. And of course, we recognize your efforts. Today, as the only non-clinician, I'll be very brief because we do want to turn it over to our subject matter experts. I can guarantee you the frustrations that many of you are feeling as regards to the rollout, the vaccine dosage and inventory is being felt. Both Fred and I are working very closely with our local partners, state legislators, federal governments, HRSA, NAC, to ensure that they understand the challenges on the ground. So what I can do as the non-clinician CEO is push. I can tell you we've been on the phone all through the holidays in preparation to make sure that our local county health departments, our state surgeon generals, and the federal government understand that not only are we ready, we're willing, we're able, and our community and those patients we serve are the priority. So again, just from Health Choice Network and my desk, thank you for all you've done. Yes, we're all running to this, try to get to this new normalcy, as Fred mentioned, this herd approach. It's a long road ahead with a lot of challenges, but I'm going to highlight the fact that we've learned a lot during this pandemic. The Alliance Chicago HCN has homed in on some missed opportunities via technology, data, and solutions. So I guarantee you that we're energized here at the Alliance Chicago and Health Choice Network to bring to you, the clinicians, our healthcare heroes, the technology and solutions that you need that we know you don't have today. And so in order for us not only to survive, but truly thrive as we come out of this pandemic in our communities and serve the patients that we serve on a daily basis, we need competing technology and solutions. So we're excited about the next couple of months as our board of directors makes critical decisions to support all our health center heroes. So with that, I'm going to pass it back on to our amazing Chief Clinical Officer, Dr. Long, and we'll get started with our panel. Thank you again.
Great, thank you so much, Alex. Appreciate those words. And also Dr. Rockman, Fred, thank you. And then also the audio cameo of Fred's dog, Raji. We really want to honor Raji today also. So we're again going to do some interaction here to keep you awake. So poll question number one. Poll question number one is, did you get the vaccine? A is yes, B is no. And Stephanie, can you help? There we go. So did you get the vaccine? So on the screen, you can either answer yes or no. And we're going to keep it open for probably 30 to 45 seconds right there on the screen. Did you get the COVID vaccine already? Either one dose or two doses, but did you get the COVID vaccine? And hopefully everybody's awake and answered our question. And the response is 57% of us who voted on today's webinar did get the vaccine or got one or two of them. And 43% did not yet, hopefully, get the COVID vaccine. And then we're going to move on to our second poll question. So for those of you, 57% that did receive the vaccine, did you get the Moderna vaccine or the Pfizer vaccine? So once again, if you did get the vaccine already, which brand did you get? Moderna or Pfizer? We'll give that just a minute for you to remember, hopefully, that you either got the Moderna vaccine or the Pfizer vaccine. And then we'll see what percentages of that breakdown from the 57% of us who voted on the webinar today that did get the vaccine. What's the breakdown of the two brands of COVID-19 vaccine? And there we go. 77% of us who did get the vaccine already did get the Moderna vaccine. And 23% of us who did get the vaccine got the Pfizer vaccine. So thank you again for participating in our quick flash poll. And now I'm going to turn it over to one of my colleagues who is going to talk to you again about some more polling and a survey that Shelley recently conducted. And so Shelley, I'm going to turn it over to you.
Thanks, Tim. Good afternoon, everyone. Thank you for joining us again. I would like to start by saying a huge thank you to those of you that were able to share and complete the survey. It was sent out on the 15th of January, so only 2 weeks ago, and we closed it on the 1st. And just in that short 2 weeks, we had a total of 752 people respond, which is just phenomenal. So thank you all again for that. Next slide, please. So this survey was targeted towards staff. So the focus was really to understand where we are currently across both of our networks with staff vaccination. Of the 752 people that responded, 60% said that they would or had already received the vaccines, and about 40% said that they either were no or undecided. And this is really important as we heard earlier in Fred's remarks, to take into consideration the staff uptake of the vaccine. It really reflects community uptake and the perceptions of the vaccine. Next slide, please. So the key reasons for those folks that did say no or were hesitant to get the vaccine were really a concern around the side effects of the vaccine, safety and effectiveness, and the approval process being a little too rushed. So these were kind of an order of the responses we got. The other key reasons were that they were worried about getting sick from the vaccine, or they perhaps just wanted to wait until the vaccine was accessible to a larger number of people, maybe waiting for others to get vaccinated before them. Next slide, please. So in terms of the responses we got, we didn't require every question after the first two. So for this particular question, we had 724 of the 752 response, about 96% of the survey respondents. And of those 96%, 68 said that they were in patient-facing roles, which is an important consideration to think about in terms of the folks that said no or were undecided about getting the vaccine once it was available to them. Next slide, please. And as you can see, the age range is kind of what we would expect for those folks that are staffed at the health centers across both of our networks, where the majority of the individuals fall into the age group of 25 to 34, followed by 35 to 44 and 45 to 54. Next slide, please. And then we did ask the question of gender identity just to get a sense of who was responding to the survey and understand, what the perspective that we were hearing, who that was coming from. So we saw that majority of individuals that responded identified as female. Next slide, please. And then unsurprisingly, we did ask the question of race ethnicity and found that the majority of respondents were identifying as Hispanic or Latino, followed by white, and then followed by Black or African American. And then of course, having a small number of multi-ethnic and Asian. So I just wanted to take a moment to compare our results to those we're finding nationally. So these results that I'm going to share in the next couple slides either come from the Kaiser Family Foundation or the Pew Research, and you'll see the links there for you to access once you receive a copy of the slides from the webinar. So among those that were hesitant nationally, the findings were very similar to what we found in our smaller survey through our two networks. So again, people were concerned about the side effects. There was a lack of trust in terms of the safety and effectiveness of the vaccines. There were concerns about the newness of the vaccine. And then of course, also the role of politics in the development process. So very similar to what we saw in our own survey. Next slide, please. So one of the positives I just wanted to share too is that the last Pew Research update that they did on whether a majority of Americans felt that they were confident enough to get the vaccine, there was a result of 60% in November of 2020 that said that they would get the vaccine, and about 39% that said they would not, and 1% that didn't respond. So we had very similar results. We also saw about 60% who either said they would get the vaccine or already did, and then 40% in our results that said no or were undecided. And just a key thing to point out here is that the percentage of people that said that they wouldn't get it back in November, the reason for that really seemed very similar to the results we've been seeing in our own survey, just that there wasn't confidence in there being enough information. And I think that's really key. It's fundamental is the information that's lacking and messaging out there that's confusing. Next slide, please. So again, this is really just important to think about because as you can see on this slide, about 79% of individuals that have been surveyed nationally have said that they would turn to their healthcare providers, their doctors, their nurses for information on the vaccine. And that's really where the trust is. That's where that social influence is that Fred mentioned earlier. So it's important to think about and important to consider as we move forward how we're going to help build the trust first amongst our staff, for those that have not either received it or declined the vaccine, and then from there into our community at our health centers. 36% of those who have not been vaccinated since the beginning of January, as of when these results came out, have said that they, or believe at least one of 3 inaccurate claims about the vaccine, and they're either just going along with that and expecting that to be the truth and not having the right information, or just hesitant overall because of the information they have access to. So it's just important as we move forward to think about that. I believe that's my last slide, so I will hand it back over to Tim.
Great, thank you, Shelley. It was a great presentation. Thank you for putting together that survey, and most importantly, thank you at the health centers for completing the survey and sending it back. And so next we're going to take that information and we're going to do one more poll question here. So after hearing Shelley's data from all of us at the health centers, of the top 3 reasons, which would you like to see more resources on or future webinar on? There's 3 choices in our poll question here. So again, A would be side effects, B would be safety and efficacy or effectiveness, and C would be approval process. So if you'd like more resources or more webinar series on one of these 3, please choose one of those 3. And actually, maybe you can select all if you'd like all. Someone can try that out. I'm unable to vote here, I guess, because I'm from Chicago. So, but if you can, try to tell us if you want side effect information or future webinar, safety and effectiveness on a future webinar, or about the approval process. And so why don't we go ahead and close that poll, and we'll see what we get here. There we go. Looks like safety and effectiveness at 81% is a winner. So we will definitely, Shelley, take that information back and talk about more resources for us on that and future webinars. So next, I'm going to turn it over to one of our colleagues at Erie Family Health Centers in Chicago. And Jean is going to join us today and talk to us about what's been going on at Erie Family Health Center. So Jean, take it away.
Thanks so much, Tim, and good afternoon, everyone. Very happy to be here. I'm going to share a little bit about our COVID-19 vaccination strategy here at Erie. Next slide. So for those of you who are not familiar with Erie, we are a community health center in the Chicagoland area. We have 13 locations. 7 of those are primary care centers, 4 of which have integrated dental care. We also have a dedicated teen and young adult center, as well as 5 school-based health centers located within Chicago Public Schools. We serve over 82,000 patients with over 383,000 patient visits annually, and we employ over 730 staff members. Training is also one of the many things that we do. We train over 300 providers, and that includes family medicine, internal medicine, and pediatric residents, as well as medical assistant training program and advanced practice registered nurse fellows. So I wanted to share a survey that we did among our staff. This survey was opened on December 15th of 2020. And we actually had a good response rate. 414 out of about 700 eligible staff took the survey, and actually our percentages almost exactly mirror the percentages that Shelley just shared. We were at around 61% of folks who said yes, they would definitely take it, 22% undecided, and around 16% saying no. If you filter that just by our non-patient facing staff, so more of our administrative staff or staff who have been working from home consistently since March, we were only at about 49% who said that they would take the vaccine, and a lot of undecideds and a higher percentage of no. Next slide. So the main reason for our undecided group that they were a little unsure about receiving the vaccine, the highest rate was wanting to wait and confirm it's safe. Concerns about the rush timeline, and wanting to wait and see how effective it is. Again, very similarly matching what we're seeing in the results Shelley shared, both of the health center survey and nationally. Next slide. For the folks in the no camp, the folks who said, no, thank you, I'm not interested in this vaccine, we still have very strong levels on concerns about timeline and safety, but you'll see the rate of folks who don't trust vaccines generally goes up to almost 30% in this group of folks who would not agree to take the vaccine. So that is something we really had to tackle head on. Next slide. So we sent this survey on December 15th, not having any idea when we might get our COVID vaccine for our staff. And we ended up having our first staff vaccination fair on December 29th. So we had a very tight timeline to really try and educate our staff and to try and address a lot of the concerns that we were seeing in this survey. We're delighted to say that at this point in time, we're at 74% of all Erie employees have received at least one dose of the COVID-19 vaccine, and that includes 80% of our patient-facing staff. And we're particularly excited about this 74% of our cumulative staff, given that our non-patient-facing staff, only about 49% of them said they'd be willing to take the vaccine just 2 weeks before we started offering it. Next slide. So how did we get to these high rates? And we are seeing many of our peers dealing with 20%, 30%, 50%, and really struggling to address that. So we just want to share a little bit about what worked for us at Erie. And one of the things that we heard really consistently in the comment section of our survey was that staff would be more likely to take it if it wasn't a hassle for them to get it. Originally in December, we were told by our local health departments that we will not be given our own stock, that we would be sending our staff to receive the vaccine elsewhere in these large mass vaccination centers that our health departments were setting up. So we took actually the survey information and we shared it with our partners at the health department and said, you know, this is what we're hearing from our staff. We really think not having our own supply is going to affect our numbers and the safety of our team members. So every week for several weeks after they announced this plan, I sent a very respectful email with Erie's positivity rate for that week, which at the time was greater than 25% and doing over 1,000 tests per week, and reminding them on this survey data and politely requesting that we could have our own stock to vaccinate patients. We found out right before the Christmas holiday that we were going to receive our own supply, which was very exciting. So we held 6 vaccine fairs for our staff. Instead of sending vaccine to all of our 13 locations, we focused our vaccinations in regional hub models, particularly for our 11 city sites that were receiving their supply from the same health department. And we did these with an expansive range of hours so that folks could come before work and we would not have to be closing schedules and affecting patient care. We were very fortunate that many of our providers, particularly those who do prenatal care and deliveries, were eligible to receive vaccine from our hospital partners who received their stock ahead of us. So they were able to access the vaccine first, and then we were really deliberate in sharing their pictures, their stories, their videos of what their vaccination experience was like, so that we could start showing our staff, your colleagues are getting it, they are still feeling fine, they want to share their experience with you. And we also structured it using a free tool called Sign Up Genius. I'm not sure if others have heard of that, but essentially we were able to create vaccination slots so that our staff members could sign up and have an assigned time instead of having long lines and folks waiting to receive their vaccine. As we know, that would impact patient care pretty significantly. I think the real key to our success was a strategy of transparent and responsive communications. We really wanted to be clear and share everything we knew about both the vaccine safety and efficacy, as well as the challenges or the things that were working well in trying to work with our local health departments to get vaccine stock. We wanted to be very clear about our tiering structure in the event that we were only going to get a very small amount of vaccine. We wanted to talk about how we were using the health department guidelines and prioritizing staff who might have aerosol generating procedure exposures or more risk of having COVID. To do that, we kept one consistent source. Erie News is an Erie email address that we use with our marketing team, so that folks are not having to look for emails from me or from other people. They can just know that if they look for Erie News, this is their source for vaccine information. We also hosted 2 vaccine lunch and learns. This was a chance for our staff to really ask us questions, including anonymously. We set up a survey monkey so that people could share their concerns and their questions without us having to know who they are. And that was our time to hear their concerns, but also for our infection control team to share reputable content on the vaccine. And we were very clear, including having slides that just said fact and myth, and really trying to take what we knew was circulating out there in social media and addressing it head on. And so some of those topics included how mRNA vaccine works, potential side effects, myths, as well as what the plan was for how we would get vaccine out once we had it. We also have an infection control email address, and we told folks they could send any questions there, and our team responded to those within 24 hours, which I think allowed a sense of comfort and showing that we were dedicated to helping address staff concerns. We also had a lot of endorsement of this from our site leadership, from our central leadership, and really our teams were trying to rally their staff members and their colleagues who were unsure about the vaccine to get their questions answered, to get the help that they needed. Ultimately, we did not mandate the vaccine at this time, but there was a lot of leadership and support to try and encourage people to take this step and to explain why we thought it was important. Next slide. As far as operational planning, we worked with our site directors to determine our COVID staffing for the clinics, again, in a regional model. And we had a work plan, and if you might remember, we again had about 5 days turnaround from when we knew we were getting the vaccine to when we started getting it in staff arms. So there was a lot of quick work to be done on how we do social distancing in our observation rooms, what would registration and checkout look like, making sure that we have eye care documentation in line in terms of enrollment and also the vaccines themselves, and that we were prepared to happen to care for any cases of anaphylaxis that might occur. We had about 24 hours to review this with the teams before we went live, but we're able to pull folks together for a meeting over lunch. And we have a very clear work plan that says of the various roles that are happening and what each person is responsible for, which really allows the vaccine teams to work cohesively and to move patients and staff through the process quickly. We are using very similar processes for our patient vaccination. We've been vaccinating patients for a little over a week, and we're able to do 2,000 patients in our first week, which we're very excited about. And we're sticking to a similar strategy in terms of transparent and clear communication. Last night, myself and my infection control colleague hosted an Instagram Live for patients so that patients could come and have their vaccine questions answered. There was also an opportunity to submit questions anonymously ahead of time. And we'll be doing a Spanish version of the Instagram Live next week also. And we've been sharing a lot of content on social media and on our website, and we are encouraging our patients who have concerns to schedule telehealth visits. We are hoping that similar strategies will allow us to be very successful among our patients, as many of our staff come from the communities we serve, and we want to make sure that we're continuing to leverage what works. Next slide. So these are some of our vaccine ambassadors. We're very deliberate about sharing, and even though everyone is masked, you can see clearly that they're smiling. So we had set up at all of our vaccine fairs, I got the shot because, and then folks would write their reasoning and take a picture. And we've been sharing this on social media as well as among our own staff. We also have buttons, which I'm hoping you all can see, that all of our staff are wearing when doing patient care, so that that can help trigger a conversation with patients who may need some vaccine confidence and allow the rapport they have with their trusted clinicians at Erie to help them consider getting the vaccine. I think that's it for me, Tim, back to you.
So Jean, that was truly a fantastic presentation. You should be proud of the work that you're doing. Erie should be proud of the work that you're doing. It's really, really phenomenal. You're really a leader in this area. So thank you so much. I know that you had to block some time for patient care today. So please tell Lee Francis that we appreciate that and apologize for taking up your time, but truly we want to thank you so much.
Thanks so much. Pleasure to be here.
Great. And next, we're going to go over to our fourth poll. Hopefully, you guys are still awake. I'm sure everyone is awake after Jean's presentation. That was really, really good. So poll question number 4 is, after hearing Jean's presentation, what % of your organizational staff have received at least 1 dose of the COVID vaccine? So what % of your organization staff has received at least 1 dose of the COVID vaccine? So it's either less than 20%, 21 to 30%, 31 to 45%, or more than 45%. So on this poll, you can only select one of them. So less than 20%, 21 to 30%, 31 to 45%, or more than 45%. So Stephanie, why don't we go ahead and close that poll? And here we go. This is great, very good. It looks like the majority, 39% or the highest, is more than 45% of your staff are already had 1 dose, at least, of the COVID vaccine. And it looks like then follow up with a tie, both less than 20% and 21 to 30%. So great job, community health centers, fantastic job. And now I'm going to turn it over to a very good friend of mine, Dr. Johan Torres, who is coming to us from beautiful Miami Beach at Miami Beach Community Health Center. So Johan, it's all yours.
Hi, everybody. Thanks for giving me this time, Tim. I'm just going to take, first of all, I do want to also say that that was a very impressive presentation from Erie. Hopefully I can follow suit. I think I'm going to take a little bit of a different tack, though. I'm just going to describe some of the our vaccine journey at Miami Beach Community Health Center and some of the challenges that we might have that we experienced so far in our vaccine journey. So this is what happened with us. Of course, we do a lot of planning, just like we've heard. As far as vaccines are concerned, we started our planning process in mid to late December, and just that very last week of December, we were given word by our health department in Florida that we were going to receive, that actually all community health, most of the community health centers in Florida would receive their vaccines in the first week of January. That was distributed as 300 doses for each of the physical locations that the community health centers here have. That's true for all the community centers that were given vaccine, including ours. And we have 3 physical locations. So we had a total of 900 doses that was going to arrive sometime in the first week of January. That same time in December, we also sent an email survey to our employees. As you can imagine, this is the last week of December, so a lot of people are on holiday. We're preparing for the new year, but we actually got a pretty good response where we got about 78% of our employees responding to that survey in the initial pass. 55% of them said no, of the respondees said no, and 45%, said yes, and 45% said no. We tried our best to even go further than just email. We actually called our employees who did not respond, that remaining 90 or so, and we only got 30 more responses from there. And there really wasn't a change in the yes or no responses. So that this mirrors, it looks like, what's been shown previously in this session. We came up with a priority plan, and this is probably slightly different than what we've seen in Chicago already. In the state of Florida, there was an executive order 2315 that was sent out by the governor that very clearly outlined who was going to get the first doses. So you can see in the right-hand side of this slide a bigger version of what's in there. Long-term care facilities and residents and staff, we have none of that at Miami Beach Community Health Center. We're a community health center that's almost entirely outpatient in our service. Person 65 age and older, and then here's the kicker: healthcare personnel with direct patient contact. So we decided to interpret that very, very literally. So even though a lot of our staff that responded to the survey were not direct patient care staff, we had to, based on this order, really just focus on that direct patient contact. So we set up a priority list based on which staff was eligible, and then second in the priority were patients of ours. We have some local medical partners. We share buildings with people who are who have their own practices with direct patient contact, and then referrals that come out from various sources. You can go to the next slide. So our setup that we decided to do to go with was we set up areas in each of the 3 centers where we could pretty much keep the people who are getting vaccinated in an isolated area, at least 2 vaccination rooms with 1 observation area in each of our 3 physical locations. At each site, we set up a team of vaccinators or a vaccination team, which included 1 vaccinator that was either an LPN, RN, an ARNP, or a PA. Again, this is in line with what was told to us by our health department, who was eligible to give vaccines. We had 1 person who's dedicated to doing nothing but documenting. In Florida, we have very, very strict documentation requirements, including reporting to some state database and some other things that I'll talk about in a second. And then we set up 1 specific person for just to observe the vaccinees. We thought this was important to segregate the duties, because we felt that especially with this kind of vaccine, with all the reports that you're hearing about side effects, et cetera, we needed to make sure that all our vaccinees were as safe as possible, and we didn't want to mess up anything with documentation. We also designated and named at least 1 vaccine, what we call vaccine emergency response doctor. So that's an MD or DO, plus 1 backup per site, where they were identified as having had experience with dealing with anaphylaxis and whatever means that is in the past. We said that they had to physically be in the center at the time that we're giving vaccines. And as most of you, as a lot of you are experiencing, we have had some of our providers not be in the center every single day. There's telehealth providers, there's staff that's working from home, et cetera. But this particular doctor was asked to stay in the center every single day that we are doing vaccines. We also shared with them a protocol that we got from immunize.org called Medical Management of Vaccine Reactions in Adults in a Community Setting. We discussed it with each of these physicians to make sure that they were up to speed and what to do, and we set up kits at each location to make sure that we were prepared for any adverse reactions that might happen. You can go to the next slide. Scheduling, this is a difficult thing for us. I don't know if everyone else is also experiencing the same thing. I know some vaccination sites, even in our area, have walk-up vaccines for people who are eligible. And scheduling, as you've heard in the news, I'm sure, and particularly here in Florida, has been very, very difficult, with lines and lines of people waiting hours to get their vaccines. We decided to go the scheduling route, so each person is given a distinct and discrete time period when they're expected to show up, whether that's staff or our patients. We put them into our EHR, so that's what Intergy is, that's our EHR. We set up a different room for each vaccination team. And we set up a vaccine, what we're calling a vaccine implementation team that involved the COO, myself, our Director of Quality Management, and the Executive Vice President of Population Health, which is one of our teams that we use to do a lot of projects, including the vaccines. As far as scheduling staff, we basically chose spaces for them and put them in into the schedule, as well as determine their priority based on their eligibility and other issues and other characteristics as well. And that was decided mainly by the vaccine implementation team. We spent the first week of vaccinating that we had vaccines just on staff, and we were able to vaccinate a lot of our staff during that time period. As far as patients were concerned, we centralized everything. So we found that a lot of people would be calling even from our own staff, asking for vaccines for their relatives, for their friends who are eligible, etc. So we decided to centralize everything, where everyone calls one phone number. We keep one registry so that we can have a waiting list for all our vaccinees. That's centralized, and it's more organized that way. We have one priority protocol that follows, again, like I said, this executive order to the letter, with highest priority being given to established patients after our staff, and then any other people in our community who are healthcare personnel with direct patient contact. You can go to the next slide. So what actually happened? The plan, as with most plans, you plan one thing and then other things happen along the way. We have never, as I'm sure has been discussed nationwide, we have never been involved in this scale of a project before. What we actually did was we maintained a vaccine registry for doses and supplies so we could plan ahead. We estimated how many days we would have, and that's what you see here, of vaccine supply given the supply that we had, and hoping for second doses as we got them. We maintained a registry of patients with their doses, including date and time. And this is in addition to all the other documentation we have. This helped us in scheduling second doses. It was actually essential. This registry helped us, and it was essential in being able to schedule second doses for the first set of 900 doses that we were able to give out in the month of January. For those of you not in Florida, just to let you know that in Florida we are required to report the vaccine doses to a main database that's statewide, that can be accessed by any clinic in Florida. We have to report, actually very recently we were asked to report our vaccine doses per day to the Miami-Dade county itself, and then we have to report to the health department. So we felt that maintaining our own registry helped us with organization. We did that even though we already had documentation requirements from other centers, other locations. We also maintain a waiting list for backup doses so that we don't waste any one dose. And that's because we run into issues with people not being able to make it, especially patients showing up and not really being eligible. So we have a backup list from our schedule, as well as a backup list from people who are not yet scheduled in our waiting list. And we have a very organized, systematic approach to calling patients to make sure that we don't waste a dose. And so far, as of today, we have not wasted even one dose of the vaccine. You can go to the next slide. Here are some challenges that we ran into in our implementation. The headlines on the right-hand side of the screen, you can see, are some of the things that led to what I call challenges in vaccine acceptance. Literally 2 days after we started giving vaccine, there was this headline, I think it was in the New York Times, of a doctor, an OBGYN, who developed very severe side effects from his vaccine, or a few days after he was given a vaccine, and ended up actually dying. It's not clear yet whether or not that was related to the vaccine, but the time period was within 2 weeks of him receiving that vaccine, so it's still being investigated. That really led a lot to some people, even in our own staff, who decided that they did not want to get the vaccine after hearing that headline. So some other challenges we faced, there's a lot of demand for this vaccine, as I've already said. Even with the restrictions that we have in Florida as to who can get the vaccine, we have a very, very high demand. It's hard to deal with scheduling those patients, and then also with telling people no. That's a very difficult thing, even if it's very clearly outlined in the news and everywhere what the restrictions are in Florida. Ensuring that all doses are used, that's another thing. As with the Moderna vaccine, there's a 10-dose vial, so you can only schedule multiples of 10, and then if you get to the end of the day and you have some left, because people didn't show up for whatever reason, you have to really work your waiting list to try to get people in at the last minute before those doses expire. And that's within hours of opening a vial, as we all know. People don't show up, like I said, and this whole idea of convenience. I find this very interesting with the demand for the vaccine nationwide and the shortage of vaccine. People still want to get it exactly when they want it, whether or not it's available to them. So what I call the weekend phenomena. And even in our staff, we had people who said they didn't want to get on our Friday because they didn't want to get sick over the weekend. We had other staff who said they didn't want to get it during the week so that they can enjoy their weekend. So it's amazing. And people with their second doses even saying that, you know, they had planned a party or some travel. They didn't want to have, they don't want to get their doses on the day that they're due. This is an interesting phenomena that we're experiencing right now as we give second doses. Another challenge with scheduling, especially with high demand, is this, and I hope no one's offended by this, chain vaccination, meaning that you vaccinate one person and then they give you a list of 10 more people that they want you to schedule. That's a difficult thing that we're facing. Again, this is part of the reason why we set up such a systematic approach to developing our waiting list and our scheduling protocol so that you know, we deal with things like this. And then second doses, you know, we did get on Friday our second doses for the first 900 that we gave out. We were told by our health department that we could only use them for second doses. So what do you do with those doses that you can't give because the people aren't here, because they don't show up? That's a big question we have right now that we're trying to get solved. As far as staff challenges, again, acceptance, as we already talked about, staffing issues to accommodate side effects. So we started doing second doses on Tuesday this week. A lot of people are calling out because of severe side effects. And how do you deal with having your staff here so you can run the clinic when so many people are calling out? Ultimately, at the end, we were able to vaccinate about 37% of our staff. That does not include about 30 people who ended up getting vaccinated elsewhere. So I think our results within our own clinical staff probably mirror what's going on in the rest of the country. You can go to the next slide. So I'm just going to talk briefly in my last couple minutes or seconds about my own experience, and I think this is important as a clinical leader in our clinic and as a physician at all. I think it's important to be very, very public about what your experience is. We've seen in the beginning of this presentation the slideshow of all the people posting on social media. So here are some pictures about my experience. Just a quick summary of my background. A quick summary of my background. It's that I am a clinician, but I'm also in administration, so I don't spend a whole lot of time with patient care compared to some of the other of our staff. I am patient facing, so I felt that I was eligible for this vaccine. And I thought initially, as we were in our planning stages, that I should be among the last, again, because I don't have a lot of patient care duty. I was convinced otherwise by some of our staff, including our vaccination team. And I also felt this urge to be vaccinated so I could be an example for everybody else. So that's what we did. The very first dose is the very first picture on the left. This is one of our nurses who have been working from day one in testing, and we felt that she should be the first person vaccinated. The second dose is the second picture. She herself turned around and gave me my second dose, and you see our whole vaccination team here. You can go to the next slide. This is the second dose that happened just literally 2 days ago. Again, we went through the same process. First this nurse who I work with, and then myself. You can go to the next slide. And then I felt that also it's important to be very, very transparent about vaccine side effects. I know these are small pictures, but the very first dose, if you're familiar with a VSA system where you get daily health checkups from the Centers for Disease Control about how your experience is with the vaccine. If you haven't already done this, if you've gotten the vaccine, I would recommend that you sign up for this website. If you're giving it to your patients and your staff, I recommend that they also sign up for this website. The first two pictures, you can see that, I don't know if you can see it big enough, but basically the summary is that I had very few symptoms, just some very mild symptoms of the first dose. The second set of pictures, the three on the right, were from yesterday. Green is not good because that basically means I had all those symptoms. I was miserable yesterday, but still, you know, I would not trade this for anything. I think it's important that we all get vaccinated, even if you're going to have these side effects. I've been very public with our staff, including yesterday and today, about what these side effects are so that they can prepare, but still encouraging them to get these vaccines. You can go to the next slide. I think that's it. Yes.
Johan, thank you so much. As always, amazing. We love to hear your story, Miami Beach's story, and truly appreciate your leadership on this. It's really, I'm sure we're going to get some requests for some of your items there. So thank you, thank you, thank you. So next, we're going to turn up to New York City, Manhattan, and we're going to hear from one of our colleagues we've heard from before, and this is Dr. Warria Esmond. So Dr. Esmond, how are you? We might want to check the audio.
Here we are. We're unmuted now. Thank you, Tim, and thank you for allowing me to share not just the settlement health journey, but the journey across New York State. I have the privilege of not only being the Chief Medical Officer at Settlement Health, but I chair the Primary Care Association's Clinical Committee. So I have the benefit of 70+ health centers around New York State and our consistent sharing that you've heard about in previous sessions. So to get started, next slide, please. Just a picture of what we're trying to do in New York. So it's projected that New York has approximately a little bit under 20 million residents, 80% of which are adults who meet the criteria for vaccination with current vaccine availability. Of those 16 million, give or take, we have approximately 3.2 million New Yorkers who are 65 and older, and based on age alone, available for vaccination. Again, we have also 2 million healthcare workers who are the first line in vaccination strategy for New York State. So when we rolled out COVID vaccines in New York, I don't know about any of you, but I was not expecting to get anything before early to mid-January. And we got notification the week before Christmas that we were going to be receiving our first allocation. New York initially has been receiving approximately 275,000 doses per week. And we have this very interesting disparate program. There's New York City Department of Health and Mental Hygiene, and we have New York State. And while New York State is ultimately responsible, because my health center is in New York City's DOHMH is who is providing us with our access to vaccines. As we all well know, phase 1 vaccination was for our healthcare personnel, those 2 million people in New York State eligible for a vaccine. And with an allocation of 275,000 doses per week, it was projected it would take us until mid to late spring to completely vaccinate just our healthcare workers alone. I'm understanding that our allocation has been increased since the Biden administration has come into office, so we're hopeful that we can move that trajectory forward. On January 19th, the program was expanded to include essential workers, and in the morning 75 and older, and by noon they had lowered the age range to 65 years and older. And this was in response to pleas. Both the FQHC, our PCA, sent a letter to the governor, the New York City mayor pleaded with the governor that we needed to open up access, because one of the reasons it was taking so long to vaccinate was that you have to coordinate and you didn't have enough individuals to really move a vaccination program along. In addition, New York has adopted an equity framework which put FQHCs right behind hospitals in terms of access, hence why we received our vaccine in early December. Next slide. So vaccine availability, I think we've heard the stories nationwide, and New York really lives a big challenge. As I stated, we got our first doses a week before Christmas, and not given what we knew about the side effects of the vaccine, not really wanting to start this campaign before the Christmas holidays, which for our staff and our community is a really important time of the year. In addition, we had, the complexity of identifying enough people to get those groups of 10 available for vaccine. And we're going to talk a little bit about our strategy for staff in a minute. At the same time, the governor is pushing a term that I really objected to, but just get the vaccines in the arms was the statement that was used on multiple occasions. But if you give it to the wrong person, you would get penalties imposed upon you anywhere from $100,000 to $1 million, depending upon the type of organization you are or the violation and administration that you participated in. We're currently required to use 90% of any allocation in the week before we can get any more doses. For example, I got 200 doses yesterday. I must use 90% of those 200 doses before I can get another shipment. Our vaccine shipment came in early, our last first dose shipment was in early January, and we went 4 weeks without any additional first dose shipment. So, which means we had to halt our vaccination program due to access. And this has been a challenge. Once you figure out the system, now we can move it forward. And of course, we're stuck with restarting that initiative. Next slide. When we talk about vaccine acceptance, I think the story is very similar across our states, but clearly our staff response and ultimately our patients' response will probably vary significantly. So when we knew a vaccine was coming to our health center, we did a survey to find out how many of our staff would be interested, just like many of our colleagues have done. And about 50% response rate. We have about 120 staff, and only 30% said that they would accept a dose. We got HR involved. We felt that the most neutral person to really be engaging staff in that conversation about vaccine scheduling was our HR, director of HR and her team. And kudos to her because we really have achieved some great vaccination rates. When we started this, when we did the survey, conversation stimulated a lot of conversations with our staff about what were you doing, why were you doing it, and of course, looking to key individuals in the organization for their answers. And of course, many of my staff came to me and said, so what are you going to do? And out of responsibility, number one, and as well as health, I felt that if I was not first online to get this vaccine, we would continue to struggle with our staff and ultimately our patients accepting vaccination. So in 5 weeks, we have vaccinated 80% of our staff. The folks who still decided not to get vaccinated, many of them are citing recent COVID infections, and they feel they have an immunity which will protect them for a bit, so they want to wait. And I'm sure behind that is the points that were made earlier by Shelley relating to hesitancy for vaccination, safety, side effects, etc. We are prepared to talk, and I'm happy to talk and have shared with my staff if they want to come and discuss it with me, please let's sit down and hear what you think. But the good news is we really have achieved a significant vaccination rate. Early on in our vaccination, obviously, we did our 1A staff, and then we went out into our community. We vaccinated our pharmacists. We vaccinated our community partners who were eligible for vaccination, because we believe it is our responsibility to not just serve the patients of East Harlem, but the community of East Harlem. And so we've got some wonderful partners, and needless to say, have long lists of individuals who are almost at a dime's notice ready to come when we make that phone call. At present, we're currently targeting patients who are 65 years of age or older. We've run our data, and we have a little over 1,000 patients who meet that criteria alone. We started with asking providers well before we started vaccinating to begin those conversations with their patients about their readiness. While we don't have good data on patient acceptance, what we do know is particularly our older patients will say yes to the provider, go home and talk to their family members, and the next thing you know, when we call them because they were on the yes list, they're now on the no list. And so the conversation needs to continue. And we know our providers as well as our staff are going to be critical to talking up the vaccine to be able to encourage patients that this is a safe and effective strategy to undertake, and how important it is for us to all be a part of preventing any further havoc from this COVID-19 vaccine. We've also talked, not just in the health center, but with my colleagues across the state, of how important it is to share what the effects, not side effects, but effects of the vaccine are, because that is really critical to prepare our patients. You know, we've heard from Dr. Torres how his second dose, and I will confirm my second dose was not pleasant. And we need to have folks prepared for that. Otherwise, they're going to think something is wrong. I had a staff member right after her second dose. She had a fever of 101.7, and she texted me in the middle of the night because she thought she may have had COVID and she needed to go get a test. And I said, no, you have a side effect of the vaccine. You know, it should resolve in 24 to 48 hours. And so she was actually much better at the 36-hour mark. We have had a few staff members who did contract COVID after their first vaccine, very soon after. And a couple that was very difficult to tell, was this an extended effect of the vaccine or was this truly a COVID symptom? So we went through a little period of confusion, and I think we need to also keep that in mind as we're moving forward. We're talking about what we will do with hesitancy and acceptance. There's a lot of community conversations because we believe a lot of those messages should be outside of our walls, but we too want to be prepared. Like many of my colleagues who preceded me, we've got lots of pictures of our staff who have been vaccinated, and we want them to be placed in a visible area for our patients to see that we have truly been vaccinated. What we do believe is that we will be able to leverage our patients who have chosen to be vaccinated as the ambassadors in the community to really talk up the vaccination strategy. We don't currently limit access to only our patients because we really think, again, the community access is important. And we'll continue on this journey until we are where we need to be. Next slide. So finally, you know, with an eye on equity, we have the benefit of a data warehouse that provides us with reporting on our COVID activities. So what you see in front of you is yesterday's report on COVID-19 vaccination. We had administered, as of yesterday morning, 319 COVID first doses. And what I want to point you to is the race and ethnicity equity. We are a community that is predominantly Hispanic. 70+% of our patients are identified as Hispanic, and a significant percentage of them do not report or choose not to report race in with their ethnicity. Our New York State Primary Care Association, we have a combined data warehouse where we aggregate all data across member health centers. And we ran a report last week and looked at race as a marker for equity in our administration across the state. And the state health centers across the state were averaging 61% Caucasian individuals being vaccinated. And I was very happy to see when I ran this report yesterday after our statewide call that our racial equity was 65%, very reflective of the population that we serve for Hispanic, and 30% of those being identifying as white. The bar graph also shows that we are really focusing in on those populations that meet the age criteria. So I was pleased to be able to run this and see that we are indeed where we need to be with our efforts that support equity. Yes, there are challenges. I think we all know what they are. I think the amount of effort it takes to get a session scheduled and assure that you're meeting the correct populations. We too have not had to waste a dose. New York City has given us the okay that it is at the end of a second dose vaccination event you have remaining doses, we are able to provide them as a first dose, but that's not, I believe, going to be the answer for long. We are currently in line to receive 200 doses a week, which is where we believe we can sit comfortably and meet that 90+% administration per week. And we hope, staffing is really our limiting factor. I don't know about all of you, but between COVID leaves and health issues, we are so short-staffed with the folks who can provide immunization to our patients that we're looking at ways to solve that. If we could get more nursing staff, we could potentially vaccinate more individuals. But we are proud of the work that we're doing. We've got a team that works tirelessly to make sure that our community is getting what it needs, and we will continue on this journey. So thank you.
Thank you so much, Warria. We really appreciate all the work that you're doing, both in New York City and New York State, and it's phenomenal work there. So thank you, Warria.
Thank you.
And so next, we're going to take it to a little bit of a national perspective, and we're going to hear from our very good friend at the University of Miami, Dr. Oveen. Oveen, are you with us?
And I'm unmuted, but am I on the camera?
Not yet, but we can hear you loud and clear.
My webcam, there I go.
There we go. Thank you, Oveen. Take it away.
Thank you. And a quick time check here.
You are good.
The
Till the
time?
bottom of the hour. 15 minutes or so?
Okay, all right, I'll keep it to 15 minutes. Thank you. And again, the shout out, a shout out to Tim, Alex, Fred, and the Health Choice Network for putting this together. It was really interesting hearing a lot of these really fascinating stories from the front of the line as we deal with this national problem. And if we could go to the next slide. And this is the group that we're working with. It's called the Florida Community Engaged Research Alliance Against COVID in Disproportionately Affected Communities. It's a statewide alliance. Next slide. We're working with several of the academic health partners, but of course the Health Choice Network is one of our major partners in our work to address COVID disparities in the state. Move forward 2 slides. So here's the data Fred shared with you. This is actually the number of cases, which is about 2 weeks ahead of the deaths. So that's why it looks a lot better. But generally, I mean, this is amazing. A pandemic that's affected 8% of the population and killed almost 1.5% of our population. I mean, when we think about it, it's now the leading cause of death in the United States. Really shocking. Next slide. And Florida is no different. Next slide. And again, before I begin all my talks, I always talk about this because it's critically important, even though I'm talking about vaccines. We still need to do this. We're going to need to do this for at least several more months. And this is where we need patience. Face masks. Next slide. Social distancing, key important, the 6 feet. Next slide. And personal protective measures up as well. So those things are always important. I tell people as I talk, even though the vaccines, we do have some vaccines already and more are coming, until we get to that magic number, we still got to keep doing all those practices that we always know is important. As far as the vaccines themselves, as you heard, we do have 2 vaccines approved, and I saw a nice distribution between who's getting them, but we have a couple more, and I'll show some of that data as well. Next slide. So, you know, this is when we were, I guess, in grade school, how we learned about how vaccines work. And again, just a little bit of overview of the vaccines. And I think this has led to some of the stuff. Initially, when we started with vaccine, you know, many decades ago, we were really dealing with the weak or killed form of the disease, of the virus or the bacteria that was injected into your body. And your body would create these antibodies to these germs so that eventually would be able to fight off the bacteria. And that was basically how vaccine development worked for decades and decades. Next slide. Eventually, we found out that you don't need the whole thing. You could just take little pieces of the protein of these viruses, and that's what we create antibodies to. So a much more simple approach. In many of our recent vaccines, this is exactly how it is. So you're not injecting the vaccine, you're not injecting the virus at all, you're just injecting that piece of protein. Next slide. And here when you look at coronavirus, there's those little red spikes there. That's what we call the spike protein. And we found out that the antibodies against that spike protein are really, really effective. And so all you need to do is find a way to deliver somehow this spike protein into the body so it could create antibodies against that. Next slide. The real genius with the messenger RNA, the two vaccines that are out there, Pfizer, Moderna, is instead of actually doing that, what they did was they inject the coding for that spike, the messenger RNA, and they found a really innovative way to do this in a lipid capsule, a little fat globlet, sends it into the cell, and then that's just the message to make these proteins. So you don't even actually inject a protein, you just inject a coding for that protein. So that's our messenger RNA. So it's not the virus, it's not alive or dead, it has nothing to do with it, it's just a messenger for that spike protein. Next slide. The interesting thing, and these are some of the companies working on them, Pfizer, Moderna, and then the Jansen vaccine is a little bit different. It actually uses another form of an adenovirus that doesn't cause illness, and that's the way it gets a genetic material into the body. It is using that thing. But the big thing is that companies have been working with this already for almost 10 years. A real wake-up call happened with the MERS epidemic several years ago. It wasn't very contagious, but a very deadly virus. And people have been working this for many years. It's not something new that just happened in 1 year. The technology was there. Coronavirus was new, but technology how to do this had been already being developed. Next slide. And obviously, Dr. Corbett, one of the lead doctors who developed the corona vaccine, was telling us in a recent presentation, several years, she had a choice doing public health research, the kind of work I do, or working in a lab, because she knew the potential of the MERS virus and other coronaviruses. So this is not something new that just came out. She's been working on these vaccines for several years. Next slide. So what do we know about safety, since we heard a lot of the people talking about the vaccine? So first of all, it's 44,000 what I call heroes, the people that participate in these studies last year. So this goes back to August. We followed these people for a long time. This is a split of the participants. One of the things I was a little bit unhappy was that not too many minorities in these studies, but they had some. Next slide. And these are, the safety, the side effects. The side effects, as you heard, pain at the site was extremely common. You heard Joanne, but very, very common. Headaches, muscle pains. Most of these are extremely mild and moderate, and most went away in a couple of days. So in terms of side effects, we do have excellent data. Next slide, and I'll show some of the other side effects for the other vaccines. And this is the efficacy, what people want to know. Well, we know that they followed these people up for several months. In those that got the vaccine, only 8 people got COVID. So not everyone who got the vaccine, yes, a few people got it, but in the ones that didn't get the vaccine, 162 got it, and that's with a 95% efficacy rate. So in terms of efficacy, we have the numbers, and I'll go through them quickly for some of the other vaccines. Next slide. This is the Moderna vaccine. This just came out. They published it a few weeks ago. So we do see that the efficacy really starts happening after a month. You start seeing about 2 weeks. It's when you start seeing some protection, but it really peaks after the second dose. That's when you actually get that booster, and that's where you get it. And here you see the same thing. 11 people with the vaccine got COVID. Nobody got severe COVID, and then the placebo is 185. So again, a very high efficacy rate with Moderna. Next slide. And the side effects, we do see some side effects. A lot of the people did get side effects. Interestingly, there were slightly fewer side effects after the second vaccine, but those after the second dose were slightly more worse. Next slide. Okay, and these are some of the side effects, but it's the ones, again, similar to the Pfizer vaccine: pain, fever, headaches, but again, most of them mild, most of them lasted 1 to 3 days. Next slide. And so these are the two vaccines. The main difference, obviously, the Pfizer, you have to have deep freezer, so it makes storage and distribution a lot harder, but they're the two that exist now. Next slide. And then this is the Jansen vaccine, the one that you saw the results. This is the one we worked on here at the University of Miami. We actually did both, Jansen and Moderna. Our team took care of the Jansen vaccine study. Next slide, again, 44,000 heroes. Next slide. And again, the effectiveness, because some people are talking about this, and as a reminder, flu vaccines are about 40 to 60% effective. It varies by year. Only 1% of the people got COVID. And here where was a lot of the effectiveness data. It was 66% effective at preventing moderate COVID, slightly more in the United States. In South Africa, it was 57% effective, which would be great because that had the new variants, which are the ones that are really concerning. But in preventing severe disease, which is what we as doctors getting admitted for COVID, it was 85% effective. And we saw the effectiveness increased over time, and no one who'd been vaccinated after 2 months got COVID. Next slide. Interestingly, the side effects were much less and were higher in the placebo group, fever being the most common. So it looks like a favorable side effect profile. Next slide. And it's only one shot, which is the most important thing. It's stable in a refrigerator for 3 months. So it's really, really good for distribution, mass distribution. And we hope it's going to be approved soon. Next slide. Next slide. It's coming soon. Next slide. All right. Sorry, next slide. And then how long the antibodies last? I just saw the internal data for Jansen, but they're all like this. We have good evidence at least for 8-9 months. We have pretty good levels of the antibodies staying high for 8 or 9 months. We still don't know whether you're going to need a second shot, but we do know that at least it protects for probably several months, but we think it's going to be a lot longer. Next year, when we follow these people for 2 years, we'll know whether you need a second shot or not, but at least the data we have now is very encouraging. Next slide. Next slide. Okay, so the vaccine rollout, you heard it's very problematic. Only about 8% of the population has been vaccinated. Next slide. And as you saw, that this is slightly different, but some of Fred's data, if we keep vaccinating at the current rate, we're not sure when we're going to achieve it. That sweet spot of wherever it is, 70 to 85%. It's probably more like 85 to 90%. It'll probably be at the end of the year. And if we don't get all vaccinated, we're going to spend another Thanksgiving with social isolation, which is not what anyone wants to do. So we really got to ramp up the vaccine efforts. Next slide. And in Florida, the same thing, the really, really worrisome pattern that you heard Fred talk about. Overall, 8% of the population has been vaccinated, but for Blacks and Hispanics, it's only 2%. Again, we've seen this in many, many states, very concerning. Next slide. Next slide, you heard already Joanne talk about the governor's order. That was me getting it. Next slide. All right, and there's clearly been a problematic rollout. All the sites talked about this, so I'm not going to dwell on it. Next slide. All right, but this is a thing I want to talk about because basically the vaccine will only work if you take it. So this whole concept of vaccine hesitancy, which I want to talk a few minutes for, is what we're concerned about. Next slide. Over the summer, we saw a lot of COVID misinformation. This is just one show that somebody at Health Choice Network sent me. Next slide. Telling people if you wear face masks, it's going to drop your oxygen levels, going to give you cancer, and the 5G towers are going to interact with the COVID virus, and you're going to die because of it. So a lot of COVID misinformation was being spread over the summer. Next slide. And the drivers of misinformation, I mean, a lot of this we know already. We have lots of reasons to have fear and mistrust. Historical abuses, Tuskegee is one, but every group has a whole history of historical abuses. We were at a time of the racial unrest from unjustified police killings, financial strains, and we saw political leaders rejecting factual events and putting forward dangerous, unproven interventions. More recently, we've had the Capitol Hill riots and then blaming Black Lives Matter and really making COVID a political thing. So our community has real reasons to have distrust and fear when we see this going on. And so vaccine hesitancy, like all behavioral issues, we need to see it as a continuum. And our job is to try to move people. They start at refusal and try to move them slowly. It's like any other behavioral intervention on how to move people along this continuum so that they actually will get vaccinated so that we don't have that curve where we sit next Thanksgiving and where we are right now. Next slide. So this is some of the data very similar to what was being presented earlier among trends. We do see that, in terms of vaccine hesitancy, I agree, it was very low. But in April, it was 77%. It probably dropped a lot now, slightly better, but 58% for whites. But you see for minorities, particularly Blacks and Hispanics, the drop is more, and less than half, about half of Hispanics will get the vaccine. For Blacks, it's about a third right now. And those are the numbers that we really have to improve. Next slide. Okay, and we've heard a lot of this. You heard some of this, but our own focus groups are running as part of Florida SEAL. We hear a lot of this misinformation. Latinos are concerned. They heard that a vaccine could make you sterile. We've heard about government tracking devices among some of the immigrant community. For Blacks, nefarious origin, why were the vaccines developed? The 5G towers, some call it the Trump vaccine. Haitians were saying about being tagged with the number 666, so when Jesus comes down. And these are the factors that contribute to this vaccine hesitancy: complacency, low perceived risk, confidence. Again, this is where the trust comes in, low levels of trust, and then the convenience, which came out at some of the other presentations you heard about. Next slide. And there's a lot of different factors, a lot of different inflection points we have to think about when we address vaccination and vaccine hesitancy. And these are some of them, but really it does take concerted effort, and it can't be just one, as I'll show in a second, one magic bullet that's going to address all of these. Next slide. And so people express it different ways in this hesitancy. Am I going to get sick after the vaccine? Why was it developed? Are they safe? What are the risks? So some of the stuff that you heard. Next slide. Lisa Hamilton has a wonderful curriculum from the Florida Community Health Worker Coalition and how community health workers can address vaccine hesitancy. But basically, a lot of it is the tools of behavioral change, motivational interviewing, the right way to talk to people, this sort of directive, you must get the vaccine. No, you are wrong. The science, showing my PowerPoint slides. That's not the way. You got to talk to people. You got to engage them in dialogue, see where they are, and try to slowly move them along the continuum. And that takes a lot of work. It's one-to-one discussion, one-to-one communication. Next slide. The World Health Organization has a lot about how to tackle misinformation, but basically it's working with community partners, listening to community, and building on science and evidence. Next slide. Most people don't want to spread this information. There's some really bad actors, some really nefarious people that are purposely doing this, but most people just get afraid. They're so afraid. They see something on Facebook and they press send. And we got to use empathetic language. Don't use blunt language, and try to understand where they're at. And it's really a one-to-one that you got to address a lot of this stuff that's playing out on Twitter, Facebook. Next slide. And again, some of the tips we've heard from our communities. Clearly, as you heard Johan, having minority physicians and scientists as spokespersons. Dr. Corbett is great, has more credibility in the minority community. For Blacks, with our community partners have told us, tell them the Trump vaccine was actually developed by a Black scientist. For Haitians, one of the faith leaders told us, well, explain to them 666 is not consistent with other biblical signs, so they're misreading scriptures is one approach. For Latinos, have Latino men and women who've actually, had kids say, hey, I got vaccinated, I had kids, was one of the suggested approaches. And we're hearing about how to address a lot of this at the community level. And I'm almost done, Tim. Next slide. And that's it. Oh, I am done, Tim. So I'm exactly on time. But basically, it is a major problem that we do have to address. We want to get out of this quickly. And we're going to have to work with the local groups, many of which, to address this hesitancy that we do have in our community.
Oveen, that was fantastic. You take a lot of complex information and are able to boil it down so everyone can hear it and understand it. I know you went through those slides fast, so we're going to give everyone the opportunity to read them on their own. So we'll make the slides available to everybody. Also, we recorded the session so people can listen to it later if you want. And I agree, I'm putting the nod out there to Dr. Corbett, especially in honor of Black History Month. That's a great thing. And then also, right, the program for the community health worker, that curriculum is fantastic. We really appreciate it. So thank you, Oveen, for everything you do. So as we close today, this is February, and again, every February it is American Heart Month. So I want to make sure that you take care of yourself. And then on the next slide, tomorrow, National Wear Red Day, February 5th. So make sure you wear some red. If you don't have red, then go out and buy a red sweater or red dress. And also on Monday is National Black HIV/AIDS Awareness Day. On the slides, you'll see all kinds of information about Black HIV and AIDS Awareness Day on Monday to make sure we do something about it and honor that. And then ultimately, we want to thank you for participating in these COVID webinar series. We want to especially thank Health Choice Network and Alliance Chicago. So better together, innovating now for tomorrow. But before we close, I want to give one quote from Martin Luther King. Everybody can be great because anybody can serve. So I hope everybody has a great day. Stay warm or cool wherever you are. Talk to you later. Bye.